Ladies and gentlemen, good afternoon from New York City. It's my absolute pleasure to welcome you all to our grand round webinar from Harlem Hospital Department of Bariatric Surgery in collaboration with International College of Surgeons US section. Today, we gather virtually with three giants of bariatric surgery, Dr. Michelle Gainier as grand round speaker, and our panelist, Dr. George Frizzley and Dr. Lee Swanstrom as panelists in discussing the latest advancement, research, and best practices in the field of bariatric surgery. As we navigate through this digital platform, we embrace the opportunity to connect with our healthcare professionals, experts, and enthusiasts from around the world. The bariatric department at Harlem Hospital has a long-standing commitment to provide exceptional care for patients struggling with obesity and related health issues. Our team of dedicated surgeons, physicians, providers in forms of PAs, nurses, medical assistants, coordinators work tirelessly to offer compassionate and personalized treatment option to improve the lives of our affected patients with obesity. Today, Grand Round session is a very hot topic. The surgery, which is very, very common, being provided in the United States as well as worldwide, which is a sleeve gastrectomy. We're going to discuss the strategies to decrease the esophageal cancer risk following the sleeve gastrectomy. And it's my absolute privilege as well as honor to introduce our distinguished keynote speaker for today's grand round, Dr. Michelle Gainier. Dr. Gainier is a world-renowned pioneer in minimal invasive and bariatric surgery. His groundbreaking work has fundamentally shaped the field of laparoscopy and robotic-assisted surgery. Dr. Gainier began his teaching career, basically in 1990, way back at the Université de Montréal, where he introduced his skills in laparoscopy surgery. Throughout his illustrious career, he has achieved numerous firsts in the surgical world by doing the first laparoscopy removal of the adrenal gland, the liver, the bile duct, pancreas, and the pioneering of the endoscopy surgery for parathyroid and thyroid tumors. He has practiced at prestigious institutions, including the Cleveland Clinic, where he co-founded the Minimal Invasive Surgery Center, and Mount Sinai in New York, where he served as the Franz Sichel Professor of Surgery and pioneered the first transatlantic robotic-assisted surgery published in Nature. Currently, Dr. Gainier is the Chief of Surgery at Westmount Square Surgical Center in Montreal, where his clinic specializes in the laparoscopic sleeve gastrectomy, which he pioneered in 2000, as well as the other innovative treatment for obesity like type 2 diabetes and gastrointestinal disorders. He's also the co-founder of the GT Metabolic Solution Incorporation, which is a startup dedicated to developing magnetic compression anastomosis. With over 500 publications and 15 books to his name, Dr. Gainier's contribution to the field of surgery are immense. His work has earned him numerous prestigious awards, including the George Bursey Lifetime Achievement Award from SAGES in 2024 and the Roswell Park Medal from the Buffalo Surgical Society. So please join us in welcoming Dr. Michelle Gainier. Now it's my honor to introduce our two panelists, Dr. George Frizzley. Dr. Frizzley is a highly respected leader in the field of minimal invasive surgery. He currently serves as the chief of the Minimal Invasive Surgery Fellowship Program, where he has trained and mentored countless surgeons, including me, helping shape the future of this critical surgical specialty. Dr. Frizzley is the former chair of surgery at Lutheran Medical Center, where his leadership and surgical expertise significantly advanced patient care and surgical practices. Dr. Frizzley has the honor of authoring numerous chapters and papers in peer-reviewed journals, and his innovative work has also extended to surgical instrument design, where he holds patents for instruments that have contributed to improving surgical technique and patient safety. So please join me in welcoming Dr. George Frizzley. Now my honor to introduce our another panelist, Dr. Lee Swanstrom. He's a distinguished professor of surgery at Oregon Health Science University and IHU Salisbury, France. Dr. Swanstrom is a world renowned expert in the foregut and minimal invasive surgery, having made significant contribution to the field both as a surgeon and a scholar. Dr. Swanstrom has been at the forefront of innovation in esophageal surgery with a focus on advancing minimal invasive techniques that improves patient outcomes. His pioneering work and leadership have made him respected authority in surgical strategies aimed at reducing the risk of esophageal cancer, particularly in patients undergoing procedure like sleeve gastrectomy. So please join me in welcoming Dr. Lee Swanstrom. Now I will pass on the floor to Dr. Michel Gagnère for his grand nonce talk.
Well, thank you very much, Dr. Sharik Nazir, for this elegant introduction. I thank also the panelists, which I know them personally for a very long time. And I thank the International College of Surgeons for hosting this webinar. If you can see my first slide, the topic is called Strategies to Decrease Esophageal Cancer Risk Following Sleeve Gastrectomy. These are my disclosures. I don't think they are relevant to this talk, but I'm also, as I said, co-author of the book on sleeve gastrectomy. Now, the first topic I would like to address is Barrett's and esophageal cancer. And I would say, quote, Galileo Galilei, who says that all truths are easy to understand once they are discovered. The point is to discover them. I'm going to start with the 10-year randomized clinical trial called the Sleeve Pass. Dr. Salminen in Helsinki has just published not a long time ago in JAMA Surgery the results. And these are the weight loss. There's a wide variation in each group comparing sleeve and Roux-en-Y gastric bypass. If you look at the curves of those average, you can see there's not much difference at 10 years. In fact, that difference is only 1.3 body mass index at 10 years. It's significant if you think that 1 point of body mass index is. What was at 10 years was evident that listed as a major complication was gastroesophageal reflux, listed there at 11% for sleeve and 0 for bypass. But interestingly, when we dig and the patients get endoscopy at 10 years and look for Barrett's esophagus, you find an identical percentage of 4% in sleeve gastrectomy and 4% in Roux-en-Y gastric bypass. Obviously not statistically significant. And there are also some differences in the GERD total score, the median being 11 for sleeve and 4.5 for bypass. But again, this did not reach statistical difference. Now, if we look at the state of New York, where the incidence of GERD, esophagitis, Barrett's esophagus, and esophageal adenocarcinoma after bariatric surgery was looked at, Dr. Altieri, Dr. Pryor, and the other co-authors, you look over time, a period of 10 years, the GERD with the various types of surgery, that not much is different over 10 years in its incidence. Further, esophagitis, I must say, esophagitis seemed to be higher with adjustable gastric band, but when you look at Roux-en-Y gastric bypass was perhaps the lowest in the curve, but they were all increasing over time. If we look at Barrett's esophagus, it was no difference between the procedures. Interestingly, the sleeve had the lowest curve compared to the middle for Roux-en-Y gastric bypass. For esophageal adenocarcinoma, the numbers were so small that we really cannot tell, but there was no difference again between the 4 different types of operation. Now, that was one study, but interestingly, if we look at, and that was New York, if we look at a whole country where there's a national health system, in France, this is reported by the University of Bordeaux, a very good group of digestive surgeons, commented and looked at the risk of esophageal and gastric cancer after bariatric surgery. This is in the surgical group of 303,000 patients. And the control group are morbid obese patients with the similar profile at the beginning of the surgery. For example, there were more than 605,000 patients. So the total reached nearly 1 million patients. We look at the incidence of esophageal cancer, the total number, there were 112 over that long period of time. And surgical group had 26 and control was 86 in percentage. So if you look at specific numbers at the bottom, the esophageal gastric cancer in total number, there were 337 and 83 in the surgical group and 254 in the control group. If we look at this, at over 100,000, the incidence was 1.5 for surgery and 2.3 for control. So it was lower after surgery. The control and the bariatric in a curve here, you can see bariatric surgery was decreasing the incidence of esophageal cancer and gastric cancer over time. If we look at specific groups of patients, you can see that there was no difference really between sleeve gastrectomy and gastric bypass over a 10-year period at the incidence of esophageal or gastric cancer. Now, what can we do to improve? I mean, those results are pretty good in my opinion, but is there anything we can improve on the GERD of patients because they have symptoms, they have to be put on medicine? We know from the studies done at the University of Freiburg that there is an intrathoracic migration of the upper part of the sleeve. And this migration appears pretty early within a few weeks or months after surgery. I think that the studies from Marmuse are quite interesting in France, in which there is a simplified laparoscopic heel repair for those hiatus hernia after bariatric surgery. This was noted that they would close the hiatus and fix the esophagogastric junction to the crus, or kind of a modified heel, so that the esophagogastric junction is now inside the abdomen. Now they combine this in their repair, sleeve gastrectomy combined with the simplified heel repair in the treatment of morbid obesity. And this was their initial paper. As you can see here, by schematic demonstration, they close the hiatus hernia with posterior cruroplasty with sutures, and then fix the esophagogastric junction to that posterior repair or the base of the right crus. Here's some intraoperative picture, the closure of the hiatal defect. The sleeve gastrectomy is then done, and there is fixation as an esophagopexy. They claim that 93% after that don't have any PPI use, which I think is pretty good, although the follow-up is pretty short. Now, we know that my former fellow at Mount Sinai, New York, Dr. David Noka, in the early 2000s, has seen the expansion of sleeve gastrectomy and took this in France, trained many people, and saw the appearance of reflux on many patients, and thought that perhaps anisine could be added to the sleeve while they're doing the sleeve, leaving a fundus doing the fundoplication, and then sleeving, making sure that there is an open communication between the fundoplication, complete fundoplication, and the rest of the sleeve. I do not have experience with this operation myself. I think we're all waiting for mid to long-term results of this operation. I think one of the Achilles heel is to get good technically to avoid getting a perforation post-op if there is too close distension of that upper part of the fundoplication. You have to remind ourselves also there are progress in pharmaceutical where we see this new drug, vonoprazan, that seems to be super powerful, used in Japan and is going to come to the Western countries and used to treat or prevent acid reflux, and we may not need to do any repair at all. What I want to say is that we should operate sooner because the results get better over time. Here's the durability after adolescence in this cohort of patient 158. You can see that the body mass index does not change. The results are much better if the patients are younger. And at 9 years, the very high percentage of weight loss. Also, the types of revision are quite low and small. Here's another 10-year done in adolescents with various groups of adolescents, and you can see that at 10 years, the percentage of excess weight loss is excellent. Here's another series at 10 years with the body mass index stabilizing between year 3 and year longer. Now, another systematic review looking at the meta-analysis of randomized control trial between sleeve and bypass have shown not much difference at long term. This is a 5-year that showed no difference in type 2 diabetes remission. In this study, Dr. Petelli, who was in the randomized control trial that was published at the same time as the Finland study, this was a Swiss study, and at 10 years with intention to treat analysis, the difference between sleeve gastrectomy and Roux-en-Y gastric bypass was no difference. We know that revision surgery after sleeve gastrectomy in France increases about 1% per year. So you reach after 11 years about 12%. And those who get revision are mostly are more at risk female patients, body mass index more than 50, and a history of gastric band and also type 2 diabetes. Interestingly, in France, mostly these patients are revised with Roux-en-Y gastric bypass, but when we look for GERD, it's 5% of the overall revision. 95% are non-GERD revision, so it happens in a very small way. Now, if for weight loss, I will do a SADI. I tend to do more hypoabsorptive surgery rather than Roux-en-Y gastric bypass for weight regain. We know that in this study, meta-analysis, that SADI or DS had much better weight loss than Roux-en-Y gastric bypass. The morbidity was the same for both groups of operations. For type 2 diabetes, if there's a question about type 2 diabetes, often it is recommended by many surgeons to do Roux-en-Y gastric bypass. I would say do a sleeve, and then you can do a SADI for type 2 diabetes. Why? Because DS is the best operation against diabetes, and you can see here at 12, 14 years, it's a more than 80% remission as a straight curve after long term. Now, to finish on the long-term mortality, this is an important concept that I want you to hear. In this study of the Kaiser Permanente group, they looked that there was much more reintervention in Roux-en-Y gastric bypass than sleeve gastrectomy at 5 years. Interestingly, when we look at 5 years, and this was a small comment at that time, mortality after 5 years was 50% higher after Roux-en-Y gastric bypass than with sleeve gastrectomy. So nobody really paid attention to that. Was it due to cardiac problems? When we look at this specific cardiovascular review of gastric bypass versus sleeve gastrectomy, we see that there's no difference at 7 years over time on the cardiac. There was more readmission, of course, with gastric bypass, as noted previously. Now, this study published in JAMA Surgery recently really put an eye opener and confirmed the previous Kaiser Permanente suspicion. This is a study that looked at 38,000 gastric bypass and 57,000 sleeve gastrectomy. And over time, you can see the mortality is higher with gastric bypass. There is more complications over time. There is more hospitalization. There is more emergency department visits. There are more reintervention. There are more reoperation with gastric bypass. The only difference was revision was mostly performed in sleeve gastrectomy because of weight regain. But those are elective revisions. Um, and the cost over time was about the same in both operations. But recently in the Annals of Surgery, a year ago, the same group went further to look at Medicaid patients, 132,000. This was 84,000 sleeve gastrectomy and 48,000 gastric bypass. And after 5 years, the mortality was 67% higher with gastric bypass over time. Now look at a different health system. In Scandinavian countries, in Finland and Sweden, they looked at long-term survival. And what happened, same thing, is that the survival was better with sleeve gastrectomy. We see a mortality of all cause was 2.8% for gastric bypass and 1.3% for sleeve gastrectomy. The mortality was 115% higher with Roux-en-Y gastric bypass. Why? Well, if we look at Ted Adams' specific cause mortality of bariatric procedure compared to the Utah driver license, this was 4 million people in Utah compared to the database of bariatric patients, surgical patients, 27,000. And what they saw was that the psychiatric problems seem to be higher. Liver disease seems to be slightly higher, and hypertensive heart. Here's again a same slide showing that. So when the mortality was looked in the Scandinavian Obesity Registry, they look at specific cause of mortality in their group, and they came with this was at 90 days, the leakage, the bowel obstruction, the heart-related, and the intoxication suicide. So bariatric surgery and suicide risk in patients. You can see that the cumulative incidence of suicides increase over time, and this may be the cause for higher mortality in gastric bypass. It can also be the emergency surgeries that we've seen in the previous curves, perhaps for bowel obstruction or ulcers, perforated ulcers or bleeding ulcers that we see with gastric bypass, and also biliary intervention are more complex than with sleeve gastrectomy, where the RCP can reach the common bile duct. So I'm going to start, summarizing this. I see a decreased incidence of esophageal and gastric cancer after bariatric surgery, both with sleeve gastrectomy and with Roux-en-Y gastric bypass. So the truth was that people were saying, "Oh, we're going to see more cancer," but the truth is we're seeing less. Ongoing investigation and strategies to decrease GERD after sleeve. We cannot really comment or recommend something at the moment. And long-term results are very reasonable with sleeve, so I would continue to do this operation. And interestingly, we see a lower long-term mortality with sleeve or higher long-term mortality with gastric bypass. So thank you very much.
Thank you very much, Dr. Gainer, for your insightful and thoughtful discussion, enlightening us for this popular topic. So I'm going to bring all the panelists, Dr. George Frisley and Dr. Lee Swanstrom. And I just heard that over 10,000 people watching us right now as we speak. Incredible. So the bunch of question has come up because our audience is complex. We have surgeons on board, we have trainee doctors, we have patients also watching us, and then we have other providers from medical field nowadays. So the questions I start from Dr. Gainian and Swanstrom, Dr. Fursley. The first question is, what are the key mechanism linking sleeve gastrectomy to increased risk of esophageal cancer? What are the mechanism involved? Because these are the question asked by the
Well,
patient.
well, the question is the mechanism of why it is lower over time, not higher.
So
So
they have
I would say because of the weight loss,
Mhm.
we know that obesity is linked with an increase of cancer by 30%. So we see higher breast in women, higher breast cancer, higher colorectal, higher uterine, ovaries. I mean, there's a whole list of cancers. And I think esophageal cancer, esophageal gastric cancer is probably increased with obesity. Now, when they lose weight, for whatever reason, it seems that this effect, this inflammatory effect, of getting these cancers seems to be lower, in spite of us observing that reflux is seen in these patients with sleeve gastrectomy. Now, reflux has been measured by the group of Torino, University of Torino, and 75% of gastric bypass patients also reflux, even though they may not get burning, there is acid exposure in these patients. So I don't know. The tendency over the last few years is that we tend to use the refluxer patients and send them for Roux-en-Y gastric bypass. I think those patients might be more at risk of developing a problem and would require endoscopic surveillance. So if we say by the different society, we have to continue to do a surveillance of sleeve gastrectomy and not doing it in Roux-en-Y gastric bypass might be a mistake, in my opinion.
Dr. Swanstrom, your input.
I might make a comment about that as well. I think, by the way, congratulations, Michelle. It was a wonderful summary of the complex literature in the field. As you know, it's been a subject of discussion for more than 20 years, the relative risks. To answer the question that was out there, I think our concern is that this will engender Barrett's, and we know that Barrett's is a precursor to adenocarcinoma of the esophagus. So it's really about the Barrett's question to some regard. And Michelle, you made a great comment on saying that these patients, when you look at this retrospective data sets, these patients to some extent are probably triaged into different pathways. Maybe less severely obese patients tend towards sleeves. Patients without Barrett's or with severe GERD maybe are steered away from sleeves. So there's a little bit of a triage going on there, and I think you hit the nail on the head that weight reduction is probably what's balances out maybe a slightly higher risk of cancer on these patients. But
Yeah, I would say that what counts at the end? Is it the development of an esophageal cancer, or is it that you're still alive 20 years later? So that's the question. We might at 20 years see a slightly tick on esophageal cancer, but if patients are not having colon cancer, breast cancer, and other types of cancer, and they decrease their heart disease and their diabetes, and they survive longer as a result, um, we might have a good equation, or we're going to focus on endoscopic surveillance of the G junction and the lower esophagus. But so far, the result of France is pretty strong, showing that there is a lower incidence of esophageal cancer. Here in Quebec, we have a similar study done by McGill University. They've looked at all the patients, because we have a national health system, they've looked at all the bariatric patients that were done over a long period of time, 20 years or so, and they saw so far no difference in the incidence of esophageal cancer between Roux-en-Y gastric bypass, a sleeve, and duodenal switch, because there's a lot of duodenal switch also done here in this province.
Thank you. I'll ask Dr. Fursley.
Michelle, again, thank you very much for an excellent presentation. Like Lee stated, very well summarized. Obviously, it raises a lot of questions, to be honest with you, at different levels. If we go back to 2003 or 2000, when we did the live surgery in New York City, if you recall. So it's now 20 years that we have data and follow-up, at least where I am, part of the NBSPIP, with all the data being collected and monitored and scrutinized and so forth. The very first thing that when I looked at the sleeve, quite honestly, with 20 years plus experience, is how it's constructed differently by different surgeons. It doesn't seem to be, number one, the same operations. You have surgeons who dissect the screws in every patient. They come around the G junction on every patient. They do cruroplasty on every patient. You have surgeons who don't even do that. I mean, it's truthfully not standardized procedure when we call it a sleeve, because I get patients to reoperate on, obviously because of two problems mainly: the GERD, severe GERD that's uncontrollable, and the weight recurrence. Now we don't call it weight gain, weight recurrence. But also we get a lot of patients with angulation and stricture at the GE junction from the cruroplasties and from the attempt to fix that GE junction either with the falciform or with the HEL. I mean, we did HEL when I was a resident. This is an operation that when you hear people talking about it, you wonder, and we did so many duodenal surgeries every week. There was no TACAMET even, forget PPI. That was the most common operation, and people survived, Anyway, so the first question is, like, I personally will tell you that I will not let anyone come next to the G junction if the fat of Belgium is in the abdomen and the angle of fish is in the abdomen, that the gastrophrenic membrane should not be touched, and nor the cruise should be touched. Because, and we do leave a little bit of what I call an ear or an appendix to the proximal G junction to be used at a later date if there is.
I think I lost you.
I said, we do leave a little extension of the very last application that preserved the gastrophrenic membrane, allowing you to perhaps in the future, I've had operations done, I have videos actually, publication, where we use this to reconstruct the hiatus and be able to do a toupee, and that little thing of stomach up there is not going to make a difference in the weight. So standardization of the sleeve has to be defined truthfully.
Yep.
That's number one. For GERD, again, this is the most common thing I still practice every day, and I do maybe 3-4 revisions, if you want, because one thing we are going to show at the next meeting, how the sleeve plus GLP-1 does not give you results as good as sleeve to RYGB. So at this moment, the preferable approach is sleeve to RYGB, at least based on our data. I will stop a moment now to allow you to back and forth discussion.
Okay.
Thank you.
Well, thank you. There's no doubt that there's been an evolution in the techniques of sleeve gastrectomy. The way we did it at the beginning and the way it is being done now is different. And I would say Roux-en-Y gastric bypass has also gone into a similar period. I was trained with Lloyd McLean, where we were doing open Roux-en-Y gastric bypass in the 80s at McGill University. And the limb lengths are much higher now. They were very short at the time. The pouch was extremely small, and we were making an anastomosis over a nasogastric tube number 18 with a running proline stitch. Now, when laparoscopically started in Roux-en-Y gastric bypass, nobody was closing mesenteric defects. It took a national Swedish study to convince surgeons that they should be closing their mesenteric defect, and still to this day, there are surgeons who do not close their mesenteric defects. And what we see in the long-term mortality of Roux-en-Y gastric bypass, this is a key factor. People are dying from bowel obstruction and emergency surgery in Roux-en-Y gastric bypass. So I agree with you. At the beginning of the sleeve gastrectomy, we were too far from the pylorus. I think we also did not dissect or identify hiatal hernia. It was extremely rare that people were closing hiatal hernia at the beginning. And now, at least a quarter, if not a third of my patients, I close hiatal hernia. And I do preoperative endoscopy on everybody to look for a hiatal hernia, if that is at least one way to detect them. They should have preoperative endoscopy. I still see team who don't do preoperative endoscopy because you want to identify the Barrett's esophagus. How are you going to find them if you don't do a pre-op endoscopy? So I agree with you. It is, however, becoming a bit more standardized. We see smaller distance from the pylorus. We see that surgeons leave a little distance between the G junction on top, that they have a little hint if there's a hiatal hernia, and most surgeons now will go and close the hiatal hernia if they see one. It's rising over time, the incidence of hiatal hernia closure during laparoscopic sleeve gastrectomy. And then I forgot the rest of your questions.
But what are your thoughts, Lee?
Pardon me?
No.
I have actually, I have a couple of questions. It was a very nice discussion because my staff, my PAs and co-surgeons, what we used to do normally as we doing like 60% of our practice is sleeve, we dissect all the left crura completely, and that's just to make sure there's no remnant, there's no hiatal hernia or any dimpling. Do you normally go and close the hiatus, the crura, when you see the dimpling, or when you has to have a larger defect in order to close it?
I at the beginning we left the fat pad alone, and now I dissect the fat pad at least on the left side to identify well the G junction. And during that dissection of the fat pad, we have a good look at the left crus. And at the base of the left crus, you should be able to see if there's a hiatal hernia or not. I mean, just relying on the anterior dimple is not enough. I mean, you need to see the left crus, in my opinion, because there's usually there could be a lipoma. You can put your laparoscopic instrument just behind and feel if there's a defect there, without doing too much dissection.
Respectful this different opinion. Dr. George Foley says that you should not go and be aggressive on the left crura in dissecting it.
Because we are doing a weight loss surgery. We are not doing something else. And the trauma and the harm that's taking place when you are in live practice by dissecting the screws and Penrose drains and you name it, and you see it live is differently than when you read the papers. You will be amazed as to how the thinking process is biased. Anyway.
What's Dr. Lee Sonstrom? What is your opinion in that?
Yeah, I would be a little bit careful. I think you really need to dissect out and fully identify the angle of His, because the number one cause of sleeve leaks and fistulas is kind of leaving that devascularized bit of cardia, because you missed in your staple line the angle of His, and that's where the leaks happen. So.
Exactly.
So it's one thing. It's one thing to clean off the left crus and take the fat pad off the left side, as opposed to circumferentially dissecting out the distal esophagus. Obviously, that's overkill for the most part, unless they have a big hiatal hernia.
Another question from the viewers is that how far you go from the palace? 4 centimeter, 5 centimeter, 2 centimeter?
Yeah, we advocated initially a 6 centimeter distance. You have to, first of all, the sleeve was done as a 2-stage operation. So when we were doing our sleeves, it was with the intention of doing a duodenal switch 6 months later. And so those sleeves were much larger because they were done over a 60 French bougie, and a 6 to 8 centimeter distance from the pylorus. Now, those were because of Picard-Marceau and Doug Hess paper, in which they were putting a bougie and 1 or 2 finger beside the bougie, then they were stapling. So imagine the width of that sleeve was not what we do today. And what happened is some of the patients did not go for the second stage for multiple reasons. They didn't want to. They had great weight loss, some of the insurance refusal in the US, etc. And then we observed that they could have a sleeve, but the sleeve was then done a bit more aggressively as a standalone operation. We went on a smaller bougie size, 40 French and below. Initially, there were people super aggressive with very small bougie and getting a lot of strictures, and I think it was increasing the leak rate on top.
Exactly.
And there are surgeons like Baltazar in Spain at the time advocated to be right at this pylorus, that it would give better weight loss. But there are some studies who don't show too much difference between a small distance and a large distance, and it affects the way the stomach empties. So I think I leave at least a 4 centimeter distance so that there is a small interim that can contract and empty that stomach.
Dr. Swanstrom, what is your method of doing 4 centimeter, 2 centimeter, or?
Yeah, I think Michelle and I were just at a meeting in Oxford on bariatrics, and there's quite a few people discussing 2 centimeter pulses, but I'd certainly say that's not standard of practice. So I'd say four probably is kind of the median these days.
Dr. Fresley?
I agree totally with Michelle and lead 4 to 5 centimeter. Believe it or not, some people leave the entire antrum. And and as a matter of fact, this brings to mind an operation that is resurfacing when I was in Cleveland at the last meeting, called the Magenstrasse operation, which is basically a upper part sleeve, then you leave the antrum, and then you leave the entire stomach as a diverticulum. And there is a company now trying to revive this operation, which is again, something that we will be having to deal with the patients to answer the questions about the long-term results and the GERD and the surveillance. We do ask all the patients with post-sleeve to have an EGD before even an esophageal very often. And at the same time, we do surveillance endoscopy, part of the protocol routinely, especially after 5 years, to look for the Barrett's or any other evidence if they are symptomatic or not symptomatic, part of the record.
Okay. The other question is, we talk about the Barrett esophagus. Do you have any protocol post-sleeve gastrectomy in terms of doing endoscopy?
No, we just mentioned our protocol, at least part of the NBS-VIP, which is basically gives you a long-term follow-up for the patient and to be ahead of the game, because like Dr. Ghanim, Professor Ghanim mentioned at the beginning, we always tell the patient to go to Google. Obesity is directly connected to 13 cancers specifically. From the brain, there is an image on Google that we distribute to patients that shows them the breast, the pancreas, stomach, the ovary, endometrium. It's right there. It's really standard photo that we give to every patient for them to understand how obesity is more harmful than the metabolic syndrome, but introducing, like Professor Ghani and Dr. Swanson mentioned before, the incidence of obesity, breast cancer, and so forth.
I don't know. I think if so, tend to recommend that patients who had a sleeve gastrectomy should have a follow-up endoscopy. We don't know if it's 5 years, if it's 10 years, how frequently they should have it. We know that what alerted us to that was the Genco study from Rome, who stated 18% Barrett's after sleeve gastrectomy. Now, I think there was a problem in the definition of Barrett's. There was also a problem in the denominator of that group, because they were a referral center for reflux after sleeve gastrectomy. So they got much more patients that were symptomatic, that were endoscoped. So the percentage was much higher than what it is in reality. In the randomized control trial of Finland, as you can see, it was only 4% at 10 years. And it was the same with Roux-en-Y gastric bypass. So I must say that we're probably going to need some sort of study comparing interval endoscopy versus only when you're symptomatic and see if it makes any difference. What I know is that if you have Barrett's esophagus, then you need surveillance and you may need some treatment and biopsies and so forth, in order to be prepared for later, endoscopic treatment. And maybe Professor Swanstrom can tell us about how he would follow the Barrett's patient post-sleeve.
Yeah. So we get a 24-hour pH study in all post-sleeve patients at a year. And those that have documented objective reflux, often asymptomatic, we will put them on a surveillance program every 3 to 5 years, do an endoscopy, always with biopsies there. So that's our protocol at the current time.
Do you treat endoscopically this Barrett with freezing?
If it's dysplastic,
know.
if it moves towards dysplastics, we'll do radiofrequency ablation of the Barrett's. Yeah.
Do you discuss this complication to the patients? For example, sleep. For example, today I had a patient, and then we told that we're going to talk about the esophageal cancer post-sleep gastrectomy in terms of strategy. And she got very anxious and alarmed and worried. Do you talk about this? The patients are preoperative.
The evidence in France is to the contrary. That the incidence of esophageal and gastric cancer is lower than if they had stayed in their obesity state.
So shall we talk about Barrett esophagus to them in terms it can develop in the future as a complication or no?
A good explanation of why you might be asking for a post-operative endoscopy or a pH test. I think it's probably fair to mention Barrett's.
So now,
certainly you're obliged to talk about reflux after sleeve gastrectomy. That's a must, I think. For Roux-en-Y gastric bypass, I think you're obliged to talk about long-term bowel obstruction. So these are the potential risks. Whether you should go up to, say, there might be an incidence of esophageal cancer because of the reflux. I don't know, because that's probably an overkill and scaring patients unnecessarily.
And another question really unrelated to this discussion today about the GLP effect. I want to Canada. What is your thoughts are reducing the practice of bariatric surgery in terms of the GLP, or has any effect?
Oh, go ahead, Michelle. Here in the United States, at least, there is a feeling at this moment that the volume of bariatric surgery has decreased close to 30%, even more, with the introduction of the GLP-1 agonist. And there has been, as you know, several programs that have shut down the bariatric program because the patient's volume is decreasing. And obviously, we see it right now on a daily basis, every day, actually, when I see patients. And then I will have to say, at least anecdotally, that there are a lot of patients who, number one, can't afford it, patients that are not diabetic that will not be approved for it. And at the same time, there are a lot of patients that have side effects to it. And also, there are a lot of patients who will not lose weight on it. So if I can tell you that a lot of the patients I operate on every week have been on Mounjaro, have been on Ozempic, have been on the for 6 months, for 2 years. And then here we have to be careful also. Now we have a new protocol to stop the GLP-1 agonists, not 7 or 8 days pre-op, but we stop them 2 weeks pre-op part of the protocol because of the gastric atony. I don't know what Lee or Michelle have to do, have an opinion on the.
Well, in Canada, I think we see the same phenomenon that is worldwide. We've seen a decrease in the volume of bariatric surgery. You speak to our colleague in Europe, in Australia, and some other parts, and they also see the decrease in volume of bariatric surgery. However, recently we've seen an increase. So maybe that was for a period of 1 year or two, and now we see patients coming back because of failures in the medication, because of inability to cover the cost, because of side effects, et cetera, that you just mentioned. And I just don't know if that's going to be sustained with the newer medication and pipeline that are coming. We definitively probably need good randomized study comparing these drugs and surgery. I think we need that. There's some recent meta-analysis done by Phil Schauer and Francisco Rubino who shows that long term, the kidneys are better preserved in diabetic if you had bariatric surgery as opposed to getting these drugs into a yo-yo thing. So at the end, you're saving more kidneys in diabetic by doing the surgery. And there are insurance company who are considering covering bariatric surgery again because it's more cost effective to do bariatric surgery than to cover these drugs at high costs over a longer time period.
And in France, the drugs are rather hard to access. So we've seen a decrease in laparoscopic sleeve gastrectomy, but it's been more due to endoscopic sleeve gastroplasty. So ESG is very popular in Europe, and that's kind of when the patients are presented with, as so often happens when they're presented with the choice between an endoscopic procedure and a laparoscopic procedure, they tend to choose the endoscopic.
And so in New York City, actually, I was just talking to one of the GLP representatives. He says because of the cardioprotective effect of GLP, now the Medicaid is going to cover pretty soon. So I'm not sure. But right now, Medicare does not cover, any certain commercial insurance cover this one. So we have started our own practice, the medical weight loss, so that we keep the patient among ourselves. And then patients, if they get treated with the medical weight loss, and at certain time they get annoyed, or they're not happy with the results, they come back and get the operation done. So that's what we are doing. Other question they talked about the technique, like which we already discussed, from there. So what are in terms of the revisional operation? We're talking about sleeve, which has been very popular. Today we got like 10 patients who wants revisional surgery. And I came from the East Coast, from New York City, and our patient population are not very intelligent and not very rich. And they don't have access to the medications in terms of multivitamins. In fact, some patients, they come in and they think that's, weight loss operation can be done and he can go home or back to work in the next day. So how we can do a big operation in terms of duodenal switch from sleeve gastrectomy in that category of the population?
Yeah.
Whether shall we do a bypass on them as a revisional operation or
well, if you look at France, for example, I know that Lee is still there in France, and mostly surgeons will do Roux-en-Y gastric bypass because SADI is not on their list of reimbursement, for example. So it's unfortunate because it's a better weight loss procedure than Roux-en-Y gastric bypass after sleeve gastrectomy. So there are sometimes insurance or code and problems for a revision surgery that plays into it.
I mean, forgive me, Michel, for interrupting, but that deserves another webinar because I think that SADI and SIPS, and anytime you come close to the duodenum for no reason, you're really harming your patient. And we have a very strong data on this and strong opinion on this. And I don't want to disagree with you on the webinar.
Yeah.
But,
we need another webinar. We can talk about magnets. That is, maybe I'm trying to convince you that's soft and less dangerous than stapling the duodenum. Yes.
I mean, we've been there. Thank you very much.
Okay. Well, thank you very much for inviting me at this webinar, and we'll be happy to as a wrap-up comment, I must say that sleeve gastrectomy is one of the most popular operations in the world. It seems to plateau in certain countries. We see a little resurgence of Roux-en-Y gastric bypass because of the reflux. Some of the patients are better identified and going into this operation. My personal practice is about 3/4 sleeve and maybe a quarter of bypass for this reason. So I'd still think, Roux-en-Y gastric bypass has its place. Um, and as far as the drug and endoscopy, they affect the mix of those surgeries over time. We have to see if the endoscopic sleeve gastrectomy will be sustained because I've done laparoscopic gastric plication and I've stopped doing it because the results were inferior to sleeve gastrectomy. So it would be surprising that an endoscopic technique is getting better result than the laparoscopic gastric plication.
Okay.
Thank you, Dr. Michel Gainier, on behalf of the Harlem Hospital in New York City and International College of Surgeons, for your very thoughtful, very insightful, and very informative presentation on the strategies to decrease the risk of esophageal cancer following sleeve gastrectomy. And I also want to thank the panelists, Dr. George Fursley and Dr. Lee Swanstrom, for the thoughtful contribution, expert insights during these enlightening discussions. And we are also grateful to our attendees. We have like more than 10,000 people watching live and also participating in these important discussions. And we'll continue to make this productive and valuable ground rounds in future. And I'd like to thank Nick Rebel from ICS and as well as Maggie Kearney from the ICS, who's managed and brought this program in a very nice way. And we'll continue to continue this conversation, advancing our work in the field of bariatric surgery. Thank you and good afternoon to you all.